we had started talking about grief and bereavement, and I think we ended up having a fairly meaningful session in general. We talked about how grief is a natural response to loss of any kind, not just death, and losses show up in different ways. We specifically focused on loss in the context of illness and the series of losses people experience as they go through the illness journey. We talked about the different frameworks of grief through the lens of the stages, and then we talked about Worden and his tasks framework, as well as mediators of mourning, sorry. And we also talked about the dual process model. Following that, we talked about the ways in which grief is experienced, how it is expressed, and how people adapt to losses, and the fact that the ways in which people express and experience grief ideally should be, there should be congruence, but that's not always the case. Sometimes, because of societal and cultural pressures, people are not allowed to express grief the way they experience it, and the kind of trouble that leads to. So today we're going to actually continue with the different ways in which grief manifests, and then we will go into bereavement and how do we support people who are experiencing bereavement. So last time the session we stopped at the section on disenfranchised grief, and disenfranchised grief is grief that is not supported in society, either because the relationships are not recognized, they're not known about, or because they are relationships that are disapproved of. The manner in which somebody has died is not approved in the sense of overdosing, suicide, etc. And so there are various ways in which people get disenfranchised, and I did end by saying that one of the high risk groups for disenfranchised grief are people in the helping professions like medicine and healthcare and mental health, because we are taught in our training not to get attached to the people that we're trying to help. But I think that paradigm is also shifting quite a bit. So today, let's get started right up with the next part, which is also a bit of it's a big one. We're going to talk about complicated grief. Right, so complicated grief is something that I think all of us need to attune ourselves to, because especially in the wake of the global pandemic that we experienced, complicated grief is now far more common than it would have otherwise been. And what is complicated grief?
Complicated grief, characterized by intense and persistent yearning or longing for the deceased, difficulty accepting the death, persistent feelings of disbelief or shock, emotional numbness or detachment, difficulty experiencing positive emotions, difficulty engaging in activities that were previously enjoyed, guilt or self blame related to the death, intense feeling of anger or bitterness, difficulty trusting others or forming new relationships, preoccupation with thoughts of the deceased, difficulty with daily functioning such as work, school, or self care.
So, on the outset, it might seem like complicated grief is like any other grief. Like when you've just experienced a loss, any number of these things that you see on your screen at the moment could be a feature of how you're experiencing your loss, right? But for when grief is, well, experienced normally, yes, you might go through all these experiences, but it happens in an acute phase, for a short phase. And then people slowly, as the dual process model tells us, or as Worden's tasks tell us, we move on. We start orienting ourselves to getting back to re-engaging with life. But the problem with complicated grief is that that doesn't happen. People stay stuck. They're stuck in all of these things. And they're unable to function. They're unable to engage with other people. And they don't move on through the various stages that normally people might go through, and they might get stuck in this sense of anger, bitterness, guilt, and acceptance of the reality of the loss is not there. Now, if you look back on the COVID pandemic, a lot of people that might have, over a period of time, exhibited this once they've lost somebody. And part of the reason for that is, complicated grief is triggered by certain things. One could be the nature of the relationship with the deceased person. Maybe it was a completely enmeshed relationship. Maybe the person depended on the deceased for everything, for day-to-day decision making, for just taking care of them, for nurture, for whatever. They had fixated on that one person, and without that person, they find that they're unable to function, they're unable to navigate the world. The second is the circumstances of the death. How did the person die? And if you look at the mediators of mourning, was it a sudden death? Was it an expected death? Was it a prolonged, painful death? Was it an overdose? Was it somebody taking their own lives? Now, if I'm going to put it in the context of COVID, the circumstances of people's death was very, very unusual in that sense. Someone would come down with some symptoms like a cough, or like some cold like symptoms, a fever, etc. And if you remember the Delta wave, very, very quickly that would just escalate into a serious condition. And then before you know it, the person is taken away, the rest of the family is in isolation, you're not allowed to visit the person. And then somebody, if you're lucky, somebody from the healthcare system is keeping you up to date about what is happening. For a lot of people, that didn't happen. They weren't getting updates also because the healthcare system was completely overwhelmed. People were wearing masks, and suddenly you got the news that the person had passed away, and that's it. And you can't even go for a funeral. You can't organize what would have been normal in when somebody in the family died, because of all the norms at the time, that we weren't allowed to be present as communities, as families, for the funerals, for the cremations, for the burials, or whatever are the rituals of mourning that we went through together. So circumstances of the death, and suddenly this person has disappeared from your life without you even expecting it. Yeah, so that's in the context of COVID. But in non-COVID, like I said, it could have been a sudden death that was not expected. In the nature of relationship, for a lot of people who've lost their children, they end up having complicated grief because it's very, very hard to accept the death of a child. Events that occurred after the death. What events occurred after the death? Now, events that occurred after the death could be conflict within the family because there was no will. Things that seemed to be safe were now threatened in terms of security. Some people might find that they're completely cut out. They no longer have a place to live. There might be massive arguments in the family because of property issues. It could be that that person was the one who managed all the finances, and suddenly there's a whole lot of debts and loans and things like that the rest of the family had no idea about. And how many of us know people who've experienced that kind of trauma after somebody has died, where suddenly they're being faced with all these crazy bills and things which they're supposed to clear off, and lack of social support. And again, that was something that was a hallmark of COVID, because we weren't able to be around the people who could have given us some sort of solace and support at a time when we were experiencing tragic losses. And when complicated grief occurs, and this is for a prolonged period of time, that all those, the previous slide, what was listed, this feeling of numbness, or feeling of anger, of unable to function, unable to make decisions, all of that, it starts to overshadow and dominate your life. And you are unable to do anything else. And chronic grief, now called prolonged grief disorder, same as complicated grief, has found its place in the Diagnostic and Statistical Manual in 2020 after COVID hit. People who work in the mental health field recognize that we had this pandemic, but what is following is an epidemic of complicated grief. So even now, if you were to look around your own, communities, you might find that there are people who've never gotten over it and who are simply unable to re-engage with life because of the way things happen. There were people who had multiple losses at that time, and multiple losses together can also complicate the grieving process tremendously. So complicated grief, there is a lot of literature out there about complicated grief. My job today is to just place it on the table. And for those of you who are interested, just a Google search on PubMed or whatever will tell you there's a lot of research been done around complicated grief. Okay, now it's very easy to confuse grief and depression. And this is a big problem because very often, especially in palliative care, we end up misdiagnosing grief as depression because a lot of the symptoms map the same way. Okay. And they have several common characteristics. And these common characteristics include this intense sadness, fatigue, sleep and appetite disturbances, low energy, loss of pleasure, difficulty concentrating, and overwhelming emotions that interfere with a person's ability to cope with everyday stresses. Something that you could have otherwise, it's a normal stressor. You've had a puncture on the road. For some people, that one stressor will just completely undo you. And it seems like like almost like a disproportionate response to something that is otherwise a fairly common stressor. And our reactions to those stressors become very, very pronounced. Now, grief versus depression. Grief, this is the difference. Grief is specifically triggered by the loss of a person. In the context of palliative care, we're talking about that. Or it could be an event triggered by the loss of a marriage. It could be the loss of a pet. It could be the loss of a home. It could be anything. But there is a specific trigger for that grief to start. And even as we're experiencing grief, initially we might withdraw and stuff, but we remain connected to at least some people. For some people, it might be family members. For others, it might be a trusted friend. Some people look to their spiritual leaders, but there is a sense of connection with someone else. Okay. And periodically, the person might experience pleasure even, and you might laugh, and you might get together and do something that actually brings a smile to your face. You're able to go back to maybe cooking if that's something that you enjoy, and so on. And eventually, in small ways and big ways, the person starts to rebuild their lives. And usually the treatment for grief is grief focused therapy, if that is something that the person needs and needs help with. Depression, on the other hand, is a mental health disorder that could be triggered by any number of factors, and those factors may not be tangible or clear. It's the person who's experiencing the depression cannot put their finger on what is it that is causing them to feel this way. Okay. And there is a loss of connection and an inability to connect with other people or to experience even brief moments of pleasure. People completely in depression, they're not able to experience that kind of joy. They might put up a facade, like, it's very hard to tell when somebody is depressed, but very often, if you see them on their own, they're not experiencing that. They might put up a front to, for the sake of others, but are they genuinely able to feel that joy and authentic connection? It's very, very, very rare. And when depression goes on for a while, it might need a combination of therapy with medication. And I am not really a proponent of antidepressants in that sense, unless it is indicated. But for cases of depression, that to restore that sort of chemical balance is very essential, to get a psychiatrist involved and to bring some medication into the picture with a lot of care. It's not about just going and putting out one whole arm's length worth of drugs. It is very important to address the symptoms and the underlying condition. And it's only through talk therapy, through various, whatever that school of thought might be, to really combine therapy with that medication and not just treat the symptoms of it with medication. And very often, if left untreated or unrecognized, even grief can show up in very unhealthy and pathological ways. And in some people, it might show up as serious disease or psychosomatic origins. Okay, so I'm grieving. There's nobody to recognize my grief, or I'm not getting the kind of social support that I need. My chores are piling on. My responsibilities are piling on. I'm not getting time to really process what Worden said, to process the pain of that grief. I'm not getting time to do it. And it might result in something like an illness. And again, psychosomatic, we've talked about it. People believe that a lot of the times it's in people's heads, but the mind and body are so connected that intense grief can manifest in the form of physical illness. And people who have not been supported properly through their grief often get stuck in a particular stage. They keep going back to feeling angry. They keep going back to this sense of denial, or they might end up, feeling guilty. about what they could have done, what they shouldn't have done, etc. And it can then become complicated grief. In a lot of people, especially young people and young children who don't have the vocabulary to express their loss, it might show up in their behavior. And also in adults, not just in young children, but also in adults. And what are behaviors of self-sabotage? High-risk behaviors, no longer caring about your own safety, uh, driving at high speed, substance use. Those are all self-sabotaging behaviors. If you've lost a person who's very close to you, you might start testing the boundaries of your other relationships. Are you really going to stay with me? There's this meme, or it's become a meme. There was a saying, but it's now almost become a meme where people say, if you can't handle me at my worst, then you don't deserve me at my best, sort of thing. People will test those boundaries, and that ends up in a lot of relationships also falling apart. Suicidal ideation or attempt, this can happen in a proportion of the bereaved, where they might seriously contemplate suicide, or they might even attempt it. And it could be because of practical reasons, it could be because of financial reasons, it could be because of emotional reasons, it could be a result of various things. And this inability to get that kind of help and support when people are grieving and it's unresolved, it stays unresolved, no one is talking you through those difficult emotions or even helping you through the practicalities of it, it can, in some people, lead to suicidal attempt or ideation. And for a lot of people, when they haven't resolved their grief, it might lead to alterations in their style of living. The hygiene levels might drop. People who really, looked after their appearance suddenly don't care about their appearance anymore. People who are very organized and took pride in being, keeping their homes organized, suddenly don't care about it. Cleanliness levels, not showing up to work, things like that. So a marked alteration, the way they eat, the way they, their nutrition levels, they're not caring about that much. So there's a marked alteration in the style of living. And disruption of important relationships could be a result of any one of the above points as well, like I said. So people who are unable to express or articulate their grief and therefore are unable to get the help, important relationships might fall away. There might be genuinely caring people around them, but because this person is stuck and is acting out or is suicidal or is just not picking themselves up, there are some relationships that might get disrupted by it and fall away. Now, how to assess grief? I'm not going to take you through all of these in detail. What I can do is I can share a note with you. These are all validated tools to assess grief. And what I'll do is, along with the PowerPoint presentation, I'll send you a little note on all of these things, so you can check them out. Some of them have the number of questions they ask is different. Some of them are more semi-structured. Some of them are more quantifiable. So you can check out any of these and see what will help you best in your practice. Now, how do we manage grief? Very important. Education. What's happening now? We're talking about grief. We're being educated about grief. How to recognize what grief might look like in somebody. It doesn't look the same in everybody. What are the mediators of mourning? We now know what questions to ask somebody that we're trying to help out. And education even to the family in question, that to tell them that what they're experiencing is normal and it is expected, and it's okay to feel the way they're feeling. If they're feeling vulnerable, it's okay to express it. Counseling is a tried and tested method. I can tell you, I see a therapist every week, and it has given me a lot of, at a very deep level, it has allowed me to process whatever it is that I'm experiencing. And I cannot underscore enough the value of a good counselor at a point like this. Now, in the Western countries, you have people who are specifically trained in grief management, but any good counselor will be able to also help you navigate this terrain, depending on the kind of person that you are or the kind of person that you are trying to help. Some people need to be directed. Some people need to just express their emotions and to find a place to talk about what they're going through and to have it normalized, some people need practical tips in how to cope better in how some of them might have destructive coping mechanisms, how to minimize those. So counseling is very important. And support groups, in some cases, it helps, especially if people have experienced similar kinds of losses. So, for example, in our children's program, we did have a few support groups for mothers of children with various conditions like renal failure or Down syndrome or things like that. And that went a long way in helping these parents find support in people who have lived experience. I, as a palliative care provider, I'm still limited in experiences that I have, and I may not be able to fully empathize with somebody in exactly what that loss has meant to them. But then somebody else who's gone through that loss might be able to provide that sort of mentoring and that kind of support. And in some cases, pharmacotherapy, medication becomes important, especially when there are massive disruptions to your physical sense of well-being and your ability to function. So pharmacotherapy is indicated in cases of extreme grief, especially complicated grief. Now, certain psychological intervention frameworks that we use, and those of you who are trained in psychology might recognize these. Cognitive behavior therapy is a very well-known phrase, and it's the kind of therapy that focuses on identifying changing negative thought patterns that might be contributing to feelings of grief and loss. And so cognitive behavioral therapy, as the name suggests, addresses your cognition around your experience and how that translates into your behavior. And usually these are very directive sort of sessions where a trained therapist will actually help you reorder your thoughts in a way that you're not contributing to this prolonged experience of grief and loss beyond what is healthy. Mindfulness-based interventions, and these are interventions that are aimed to promote acceptance and the present moment awareness to reduce stress and to improve emotional regulation. Now, for a lot of people, doing a task becomes very, very therapeutic. Like they don't want to sit and talk about the emotion. And again, remember, intuitive versus instrumental, right? So you have to really find out whether the person you're trying to help is someone who's willing to talk about their emotions, but also be mindful that they're not getting stuck in the talking about it. Some people get stuck talking about it over and over and over again, which might be leading to their recurring thoughts and those patterns just reinforcing what they're going through. Mindfulness-based interventions, I personally found in my case to be very therapeutic, and mindfulness-based interventions can be creative. It can be from the creative arts. I have a friend who's an art therapist, and she just came home and she told me to start painting a wall with flowers. And I said, I've never painted a wall in my life. I haven't painted anything in my life. I don't consider myself an artistic person. But she guided me through it. And I wish I had a picture to show you, but then there's this wall in my mother's house where she got me to start painting. And she said, every time you feel anxious or you feel an anxiety attack coming on, or if you feel like, you're spiraling into some sort of a grief spiral, why don't you just go and paint a flower? And I have to tell you that by the end of the month, there were over 30 flowers on that wall. But that mindfulness-based practice of sitting down, focusing on the art actually really helped a lot, because it helped me still my thoughts and actually focus my attention somewhere else. So it had a calming physiological effect on me. And sometimes that is what is needed to stop this spiraling out from happening. And so mindfulness-based interventions can help. Please also remember that not everybody is cut out for things like mindfulness-based meditation. Sometimes people do not want to go inwards at that point, or going inwards might actually make things worse. So you want to bring them out and make them focus on a task outwards that is soothing, calming, that has no goal in mind in that sense. Narrative therapy, and this is a therapy that focuses on exploring and reshaping the story we tell ourselves. And this is actually a beautiful way. I personally believe that storytelling is a very, very powerful tool. And all of us are protagonists in our stories. We have a role that we play in our stories. I am so-and-so. My mother was this kind of person. So what are some of the stories that we tell ourselves? Can I just stop sharing for a second? Because I'm particularly interested in where storytelling lands for everybody. So what are some of the stories that it doesn't have to be your story particularly right now, but what are some of the stories you've heard people tell about themselves and about their families? Okay, so what are some of the stories we tell ourselves or you've heard people tell themselves? I'll give you a hint. Okay, stories about hard work. Okay, fine. I'm a survivor. I have gone through so many losses in my life. I have survived a lot. I know what hardship is. Yeah, survival stories. So people start pegging themselves as survivors. Okay, there might be others who might say, no, my job is to keep the family together. That's my job. There might be a man who might have faced a loss as a young boy and was told that he's the man of the house. That's his story in his head. I'm the man of the house. I have to look after everybody. I have to provide. This is a script. And the more we tell ourselves the story about ourselves, the stronger that role becomes. So there's this beautiful book. I don't know, some of you, especially women, might have read it. It's called Women Who Run with the Wolves. And there's this really beautiful part where she says, when do we stop becoming survivors and start to thrive? It's when we stop calling ourselves survivors. Yes, self-pity stories. Yeah. So stories of, my family has always had it so rough, but we overcame all odds. Not all stories are negative stories. Some stories are powerful stories of strength. This is a family that has come through so much, and we're strong people. We come from a line of very, very happy-go-lucky people who are able to face anything. But women who run with the wolves, Rachel, that's the name of the book. So the stories we tell ourselves, if that story has a particular role that you play in it, and you keep on, rehashing that same role, you're not going to get out of that role. That is your role. So narrative therapy helps you to reshape your story. And a good narrative therapist will make you revisit parts of your story and rewrite your script. And that is a great way sometimes to get out of this rut that we find. Why does this always happen to me? Why does this always happen to me? I'm always getting into terrible relationships. People are always abandoning me. Okay, so there are different styles. I'm not saying any one of these CBT, narrative therapy, mindfulness-based interventions, not any one of them is better than the other. But you have to know what works for you and to mix and match these different therapies. And it's particularly useful in managing grief or to reorient yourself to grief and loss and then re-engaging with life. Okay. Acceptance and commitment therapy. I have to confess that I don't know a lot about this particular intervention, but this is one of the therapies that have come up in the literature of grief management. And it really encourages people to accept their feelings of grief while also taking action towards goals. Now, as I'm saying this, I'm thinking that actually my therapist has been doing this with me because, when I say I'm so angry, shouldn't I be feeling something else by now? No, it's okay. It's fine. Forgive yourself for feeling angry. It's okay. It's fine. Let's work with that anger to move. What do you want to do for yourself next? So accepting yourself and sometimes accepting the feelings, especially when those are negative feelings, is very, very difficult. So acceptance and then committing to act from that point and towards betterment for where you're at is ACT therapy. Trauma-focused therapies, a lot of people might need this because, especially for individuals who have experienced traumatic grief, such as a sudden or violent loss of a loved one, or the fact that it was a very traumatic relationship to begin with, and the death itself has left a lot of trauma wounds and the person is experiencing post-traumatic stress disorder. It might be that the process of the illness was so traumatic that multiple surgeries went wrong or horrible things happened at the hospital. And, towards the end of it, everybody in the family is traumatized. So a lot of people who have gone through a difficult illness journey will have feelings of trauma and post-traumatic stress that need to be worked through with a trauma-informed person. Okay, so the choice of framework really depends on your individual specific needs and also the therapist's expertise and training. Now, if I am not adept at ACT, I should not attempt to do it by reading a couple of books about it, because the dissonance between my training, my personality, and what I'm trying to do will come through. There is something called REBT, Rational Emotive Behavior Therapy, which really challenges a person's way of thinking. So if someone is saying, I'm feeling suicidal, an REBT specialist might say, why haven't you done it yet? But if I'm not a confrontational person, I will not be able to pull that off. And if I use it on a person who's not good with confrontation, I can cause more damage. So you have to be very careful in the intervention that you choose. One size does not fit all. Please go through the mediators of mourning. And you might find that at different times in the journey, the person needs different things. So make sure that you're able to pivot according to what the person needs and not just impose your framework on, no, we are going to go through the 4 tasks that Worden laid out. No, sometimes you can't do that. Okay. Um, so grief counseling goals, irrespective of the framework that you choose, is firstly to increase the reality of loss. And when I say that, I don't mean that in a cruel way. It's to, maybe a better way of putting it is to help the person accept the reality of loss. Okay. And it could be small things like, hey, how about we clean up that person's room now? You know, are you ready to start donating their clothes to charity? You know, maybe there are things that we say, okay, how about we now go and, you know, close that bank account? Things like that. So it's to increase the reality of the loss and to say it has happened, and I'm going to help you slowly accept that the reality, that the loss is real. To help the bereaved deal with both the experienced and the latent effects. So on the surface, I might say, yeah, sure, of course, you know, like, and I'll tell you, like, for me, I was my mother's primary caregiver for years, not just months. And of course, it became like my primary role in life for the last 5, 6 months of her life. And so on the surface, it was like, yes, of course, you know, I've got all the palliative care doctors. I know the decision-making process. I know that at this point, we're not going to take her to the hospital. We're going to take care of her at home. And I'm okay with this. And I found that I was explaining that to my entire family, and I came across as this competent person. But the latent effect I later realized was that um, I had um, I had some bitterness about it. I had uncertainty about the course that I had taken. I had unresolved issues of, you know, the fact that my mom died when I was not there. I felt angry that, you know, after all of that time, I had that experience. And so my counselor has been great in that sense, where she's helped me also say, okay, you know, let's talk about what you're not talking about. Let's talk about things that you're omitting. Okay, when you talk about this, I find that you're constantly talking about, you know, how supportive everyone else has been around you. But let's talk about the fact that how supported did you actually feel at that time, or if you feel like you're still doing the heavy lifting. So to help the bereaved deal with both the experienced and expressed, as well as the latent effect of the loss. Um, to help the bereaved overcome impediments to readjustment. I might be self-sabotaging. I had basically locked myself into that house and said, no, I have to, you know, have all these things to take care of. I have the dogs to take care of. I have to secure the house. I have to make sure the people who work here are taken care of, etc., etc. And for all practical purposes, I had just stayed over there, refusing to re-engage with the rest of my life for a certain period of time. And it was actually, again, it was through good counseling that I was encouraged to finally leave that space and come back to where I live and to re-engage with life on my own terms. And basically, in that sense, it was an impediment, you know, because my thought process had gotten stuck, saying, no, I cannot do anything till I do this. So those kind of ways in which a person might say, okay, what is the worst case scenario? What will happen if you actually just leave everything right now to handle itself, and you carry on? And I said, no, my God, everything is going to fall apart. But did everything fall apart? No, it didn't. So that my own thought process was an impediment to me moving on and readjusting. For other people, it might be other things. The fear of living alone. Maybe some people need to move homes because everything in this current house or this flat reminds them of that person who they died, who had died. So helping the bereaved overcome impediments to readjustment, and to encourage the bereaved to make healthy emotional withdrawal from the deceased and reinvest energy into other relationships. And these are not necessarily, I mean, this is not that you're replacing the person, but a lot of people feel guilty that they're moving on, that, you know, especially like spouses who've lost their partners, they might find that they're unable to move on to another relationship. Um, for others, it might be something different. So to really encourage the bereaved to make a healthy emotional withdrawal from the deceased and reinvest energy into other relationships and say, hey, you know what? Um, now, now that your parent has passed on, how about you pay more attention to your relationship with your siblings? Because they've also experienced this loss. How about you guys do something together that is not about, your unwell parent? And again, for me, it was that every time my brother and I spoke, it was always about my mother's health. And it was like, I think I've mentioned it where Dr. Raj said, Smriti, you better start talking about something else with your brother. Otherwise, you guys are going to have nothing to talk about once she's gone. So we did work on that relationship, and that has actually been a very, very important factor in dealing with the grief and moving on. And most people, again, I'm not going to say it's a hard and fast thing, but most people resolve to a level of functioning around 1 year later. Some individuals and families might need more time simply because of practical reasons or because the families living apart or conversations need to be had, or there are other logistical issues or legal issues that need to be taken care of. And I think this is important for all of us. We all of us need to advocate for sufficient time off from work for the bereaved, especially in the first few weeks of bereavement. Now, I would even go a step further to say that yes, in the first couple of weeks, especially when it's a close loved one who has died, you need that time to really take care of practical issues and, the funeral and the prayers and this and that. But I would say that, maybe a couple of months down the line or sometime around then, having a week off from work just to then process that emotion could be a very helpful thing, because it's only after that period of taking care of immediate legal issues, financial issues, rearranging your living space, etc., when you finally may need some time to just really at a spiritual level come to terms with the loss that you've had. So I would say let's all advocate for bereavement leave, maybe a week soon after the passing of somebody, and maybe a week later where it is paid leave, where the person has the ability to then really attend to their difficult emotions and feelings. And what you really need to remember and remind people that you're helping is that grief spikes can continue for the rest of your life. And like I said before, you grow around the grief doesn't recede. And especially around special events, holidays, anniversaries, people have more acute reactions, or they might feel the loss more strongly at those times, and that's perfectly normal.
Ma'am, I think first we need to intervene with the caregiver, because that is the foremost thing which we need to address. That is a gateway to convince the child, or even make the child feeling better. So since we are professionals, we will once only meet the child. The caregiver is supposed to be there 24/7. So what the caregiver is, actually speaking or having a conversation with the child, that exactly creates an impression in their mind. So this self-blame can be a byproduct of these conversations and many other concerns by the caregiver. So through caregiver, we can intervene in a very better way to the child, and their reciprocity matters a lot, I guess, ma'am.
No, I agree with you. Thank you. And this is also important. We cannot go to a minor child without the consent of the parents. So what you have highlighted is a very important aspect. And I think what I'm also getting from you is the fact that there has to be some sort of psychoeducation of the caregivers, of also helping caregivers understand what might be going on with the child. Using language like this might actually make the child feel more guilty. So let's try not to use this language. Yeah. See how many times to tell, because see, remember, this child is having difficulty with the food in the hospital. The child is feeling isolated. There's some irritability going on. And very often, sometimes the way the child is corrected may actually make the child feel even more guilty. So thank you very much, Anne. That was a very useful intervention that you gave us. Yeah, Shiv Kumar says, involve the parents, through them create an awareness. Yeah, pretty much I think on the same lines as what we just discussed. Okay, any other thoughts? None? Okay. Then let's move on. The final session, the final part of this I know we have a case presentation, so Kuheli, I'm going to try and wrap this up quickly. We're going to talk about bereavement. So we've talked about grief. We're now going to talk about bereavement. And bereavement is actually it's a period of intense suffering. It is the actual event of the loss. Okay, and we use bereavement in the context specifically of death. And bereavement it's a time of acute suffering, intense suffering, impaired interpersonal and social relationships in the family amongst caregivers might be something that happens now. This is a particular time which is associated with elevated risks to mental health, morbidity, and mortality, okay, especially if people are very, very close. And 10 to 20% of people have a difficult time integrating the loss, even at the time of bereavement. So bereavement is the actual event of loss, okay? Now, following death, we have these. First of all, there's the immediate loss of the person itself. Then there are the secondary losses, like we talked about. My role suddenly as a caregiver has ended overnight. Now, what do I do with all my time? How do I re-engage with my life? And support. I've suddenly gotten very close to the palliative care team, and now suddenly they're going to stop coming. And, you know, they were a big source of support for me, but there's no reason for them to come back. You know, my whole day was just involved with doctors, nurses, etc. I've developed these relationships with these people. Now I'm not going to be talking to them on a regular basis. And there are many other secondary losses, of course. And of course, further losses, loss of income, hopes, dreams, roles, all of those things that you had sacrificed, which you now suddenly, you know, the reason why you sacrificed all those things is gone. Now, where are you left? And how do you deal with that, reintegrate with that? Now, each of these stages requires adjustment and adaptation. Okay?
Next one.
Okay. Now, what are some of the emotions that you would feel at bereavement? Very quickly, come on, let's hear from everybody. At the time of bereavement, what are some of the emotions that people feel? Anyone? Ominous silence. Mental pain, apathy, grief, blank. Go on. Shock. Survivor's guilt. Yes, big one. Tearfulness. Stress. Yeah. Okay. So, anger. You could also feel anger. Okay. Numbness. Some of you have said blank. Some of you have said, you know, shock, numbness. Okay. Panic, anxiety. Some people feel like very stressed out and anxious, and you know, there's fearful responses, things like that. Relief. Some people might feel relief because the person was suffering so much that finally the suffering is over. Okay. And guilt. A lot of people might feel guilt. So there's sadness, anger, numbness, panic, anxiety, relief, guilt. So it's what I'm trying to say is it's a very messy time. Different people are feeling different things. Okay. And anger is a particularly difficult emotion. And it's not necessarily only there after bereavement. It might even happen before. Social attitudes. And we don't encourage anger to be expressed because it's considered a negative feeling, right? So, you know, control your anger. We say that to people. And it's also a very difficult emotion to express in a way that is healthy, because it's also a very powerful and menacing thing. And sometimes it just shuts off the rational part of your brain. And then you end up saying a lot of things that you don't mean to say. So anger can really be something that can take over. So you're afraid to express it because in case I start expressing my anger, I don't know what is going to come out of my mouth. And many people cope with anger without expressing it. And this is a terrible thing to do because, and also, you know, it's also difficult to express anger against the person who has died or the person who is sick, because we say we shouldn't speak ill of the dead, or we must respect people. Now, if you've had a difficult relationship with a person, that's not going to change just because they're unwell or they died. Someone doesn't become a saint overnight just because they've got a cancer diagnosis or that they have died. They still were human through their lives. They might have caused a lot of pain to other people, but we are not allowed to talk about that because it's not condoned in society. And unexpressed anger often will come out in very terrible ways, like hurt, silent grudges, guilt, overreaction, or irrational explosive outbursts, impaired social functioning, social withdrawal, depression, apathy, low self-esteem. All of these things might be a result of just unexpressed anger. So we need to find ways to encourage people to express their anger in a way that is safe and healthy. And this is something that takes skill, but having people suppress their anger is actually very, very unhealthy and can be very damaging in the long term. Okay. Now, once bereavement has taken place, please look out for these protective factors. Who are they having secure, relationships with in the community? Find those people. Okay. What are they have all kinds of coping styles, but look for the healthy coping styles. And this is where your mediators of mourning becomes very important. How did they cope with previous losses? What helped them then? Those are the resources that you have to go back to and remind those people to tap into it. Social support, always a huge protective factor. You have to figure out this is where your eco map will help you. Who do they have in terms of social support? It could be their church group. It could be their people who they go for evening walks with. It could be, a card group. It could be a sports club. It could be whatever else, people that meet there. So where is their social support coming from? What is their ability to communicate? Some people are good communicators. They're able to express themselves. Some people are not. And so if their ability to communicate is more in terms of non-verbal cues, look out for that. Get them to express themselves in that way. Appropriate and timely healthcare responses. I mean, this is ideally something that should have happened before bereavement. But, if I don't get that timely healthcare response, it's going to actually complicate my bereavement. I'm going to feel angry about it. I'm going to feel guilty about it later. I might feel helpless, and that might lead to more anger later. Okay. And when you're providing bereavement support, what is your aim? Your aim is to identify and support healthy coping strategies, reduce risk factors like, people being isolated, people not being able to communicate, people not feeling safe enough to communicate. So those things are risk factors. Identify and facilitate the protective factors that I just shared with you, and establish a channel for further support. Now, I've been here with you through this time of illness. I'm here with you during this time of death. It does not end. I will be there for you in the future. So establish that channel for future support, because people need bereavement support for up to a year after someone has died. Okay. And very quickly, there are 5 stages that this is our perspective. There are different ways that people do it, but this is a sort of a framework that seems to work. First, your bereavement support doesn't start when the person has died. Your bereavement support actually starts right when you meet the person and the family for the first time. If they have a life-threatening condition and an advanced illness, your initial intake and assessment itself becomes important. I'll tell you in more detail about that. At the time when they're about to die, imminent death, on the day of the death, 2 weeks after the death, and 1 month after the death. So these are the 5 times at which we engage with them. Okay. What do we do at each of those engagement points? So at the initial intake, first of all, assess the caregiver's risk of complicated grief. What is their relationship to the person? Are they aware that this person is has a serious illness? Are they in denial? Have they accepted the prognosis? Which is why in your case presentations, we ask you about insight into prognosis. If there is an elevated risk of self-harm or current high levels of psychosocial distress, please bring in a psychologist right from the start, if it is possible, or a counselor. Provide information and psychoeducation. And psychoeducation should ideally focusing on preparing the caregiver for the type of role that they're going to have to play as the disease progresses. Outline palliative care, external services available. A lot of people don't know about palliative care. Assist the primary caregiver to support their relatives in terms of, their loved one, in terms of symptom management, psychosocial support. As a caregiver, it helps me if I don't feel helpless and someone teaches me, okay, this is how you do bed sore prevention, how you change positions and things like that. It helps me feel more empowered. Self-care strategies for primary caregiver.
including giving them respite services if possible, and information on death and bereavement. And this is not like, we don't accost them with this information. We ask them what their ideas are. It's not a comfortable conversation, perhaps, but understand, slowly breaking into that conversation of, okay, what are your ideas about how serious this person is, etc., etc. Now, the second engagement point is when you know that the person is towards the end stage, they're going to actively start dying soon. So assess the family's preparedness. Are they ready for this? Discussions regarding death decisions. Okay, do you want to take this person home? Do you want to be cared for here, etc., etc.? Do you want some sort of sedation? Those kind of things. Now, ensure that the family is aware that death is imminent. Make sure that they know it's happening wherever it's possible. Provide practical information such as signs of imminent death, like, this is for palliative care teams. We do this quite often. Okay, you'll notice that the breathing is going to change. It's going to sound like very wet breathing. We explain that it's not that they are suffering, it's just that they're unable to swallow. We talk about the fact that their extremities might start feeling cold, things like that. For those at risk of complicated grief, provide more comprehensive support. There is someone in the family who is looking like they're not going to take this well. Get more family members around them, get prepared for that. And practical decision-making support. Who do the family and caregiver wish to be present? Where would the caregiver and family like the death to occur? Who should be notified? Things like that. So you're really helping them to think. Otherwise, a lot of people get very clouded at this point. The third engagement point is at the time of death. Assess the level of trauma that the family is experiencing, and provide the kind of appropriate support where needed, and connect with social support systems who the bereaved trust. Bring in, their priest or their neighbors or whoever it is that these people find support in. Assist the family in filling out documents. This is important. At least one palliative care team member should be with the family and at least till they leave the hospital premises, and a medical person connected to the care of the deceased to answer any questions, ideally, if that's possible, because they might have a lot of questions at that point, and these are medical questions. 2 weeks after the death has happened, we have to assess the level of adaptation through it could be an informal telephone phone call, or it could be a home visit. And a way to get into this conversation is inquiring about rituals, ceremonies. How are the other family members doing? Assess functionality and level of engagement. Are you thinking of going back to work? How are you managing things at home? Things like that. Share a positive memory or ask them to tell you about the person who has died. Very often people want to talk about the person who has died. Usually a positive memory is a great way. Like, hey, I remember when we were looking after your father, there was this one time where he made this joke and it cheered me up. Something like that really sort of helps the caregiver also then share something. Offer specific practical assistance that you can follow through on. Don't say, call me anytime, because you don't want them to call you at 3 o'clock in the morning. So very practical assistance, saying that, hey, if you need any information on XYZ, you can reach me at this number at this time. Here's my card, here's my email, things like that. Bring up any other concerns they may have shared with you earlier, and ask how things are on that front, but only if it's appropriate. Now, sometimes siblings will argue about place of care. One sibling says, take her to the hospice, to the palliative care unit. Another sibling says, no, absolutely not. We will take care of this person at home. Now, there is some sort of a conflict going on between the siblings. Maybe address it and say, are things okay between you and your sibling? Or, is there any question that we can answer that might help you resolve something? So those kind of things, but only if it's appropriate. And finally, 1 month after the death. Why 1 month? Because now the ceremonies are over. People have left. This is where the caregiver is finally alone and dealing with the loss. And when the ceremonies die down, the friends have left, the neighbors have carried on with their lives. This is where the secondary losses and all of those things come in. So this is when a check-in is really helpful. And this is where we also explore for things like physical health issues. Are they still getting enough social support? If they're not, then maybe give them information. Ask landscape questions around plans. Are you thinking of taking up a job again? How are you spending your spare time now? And what might they be struggling with? Okay, finances, relationships. And don't shy away from addressing, you can't see that slide, it says addressing the dead by their name. And my final do's and don'ts for you is, when you're talking to a bereaved person, please don't, like I said, call me if you need anything. It puts unnecessary pressure on the bereaved. Already they're trying to do so many things. Now they have to think of what to ask you also. Instead, and if they ask you something, maybe you may not be able to give it. So instead, offer them specific forms of practical support that you are able to. Maybe cook them a meal, maybe take their children and babysit them, maybe, pick up the elderly parents, things like that are within your control. Don't avoid taking the deceased person's name. I cannot underscore this enough. It's really important for the person to be able to talk about the person who has died. If you didn't know them very well, ask them to tell you something about them. Tell me more about your dad. I'd love to get to know a little bit more about him. Don't rush in to say something for the sake of it. And some of the things that we say is, it was God's will, at least he's not suffering anymore. Those things do not help. They do not help. So rather, being silent is a very powerful way to show your presence. Don't rush in and say something for the sake of it. And things like, he's in a better place. I mean, we've talked about that just now. You have to acknowledge that this loss is a deeply painful loss. And that's all you need to do. And avoid comparisons or telling your own story. Allow them to feel their own emotions. Okay. So we will share these slides with you. I'm just mindful of the time because Kuheli has a case presentation. Kuheli, I'm going to ask you to please take us through it quickly so that we also have time to discuss that and any other residual thoughts and feelings that people might want to share at the end of this session. Okay, all yours.
Good afternoon, everyone.
Good afternoon.
Myself, Mrs. Kweli Datta. By profession, I am a social worker representing Palliam India EIPC, West Bengal. A male patient X, whose age was 58 before death, was diagnosed with CA lung, whose occupation was taxi driver. Next. He had 6-cycle chemotherapy, 15 radiation, vomiting, pain in chest, neck, leg, and his both hands. Insomnia, constipation, poor appetite, filaria, bed sore, high blood pressure, metastasis in liver and bones. Next. He was in morphine 10 mg, Ondem, multivitamin, Pan 40, T-bag ointment, lactulose syrup, diaper, airbed, given from Pam India, amlodipine 5 mg, bed sore dressing. Next. Patient and family were aware of both diagnosis and prognosis of patient disease and treatment. They were unknown with the term palliative care. Patient understood his prognosis as he was present while discussion with his medical team. Patient family never hid from him. Next, please. Now genogram. Patient parent passed away long back and he has one brother with whom he had weak bonding. Patient was married and his wife was his primary caregiver. He also had a good term with his two daughters, sons-in-law and brothers-in-law. Patient used to stay with wife and elder daughter. Next. Now EcoMap. As you can see in this slide, he has good bonding with his daughters, sons-in-law and brothers-in-law. He has good social relationship with neighbors, friends, workplace, panchayat, etc. Even patient was well connected with our teams, doctor, nurse, and social worker, also with his treated hospital. Only he has poor connection with his brother's family. Next. Socio-economic overview. Patient was diagnosed with CA lung and was a taxi driver used to live with his family in a village. He left behind a wife and two married daughters. His wife was a primary caregiver and was a very caring person who took care of her husband until his death. The patient's health condition was so bad that was brought of his wife's father's house in city to give him better comfort. Patient's financial condition was poor as he was only the breadwinner. His younger daughter was managing his treatment costs as she does job in a private sector. Even patient's mother-in-law was also helping during the treatment. Even after the death of the patient, his younger daughter and brothers-in-law are helping his wife financially. His elder daughter had a love marriage with different religion boy, but she left her father-in-law's house as she could not cope up with them. Now she is living at her father's house. After the death of the patient, his two brothers-in-law brought her sister, wife of late patient, to stay with them at their house. Patient wife is a housewife from the beginning and now totally depending externally. Next, diagnosis of the disease. Patient was in distress for multiple reasons. Diagnosis of the disease: tremendous pain at his neck, chest, leg, both hands. Dead sore at back, for which he was in discomfort and unable to sleep. Patient was very worried because his elder daughter was not happy marrying a boy from other religion, so she stayed at her father's house. Patient asked us why I got this disease like cancer and filaria. Why was in so pain? He was unable to sleep due to his pain. Caregiver concern. The husband spent his whole life in earning and sacrificed his happiness for his family members. But in return, at the end, he got sad death with cancer. If he would have lived with me for a few more days. She was crying during our visit, feeling guilty if it could have noticed much earlier. She said she has accepted her husband's death as she was aware of the prognosis and the patient was in pain. She is now financially dependent on others. Next, please. Patient was physically discomfort due to several symptoms such as pain, constipation, vomiting, bed sore at back, disturbance with sleep. He shared warm relationship socially and was having poor economical condition. Psychologically, he was depressed because of his daughter's marriage issue, his own diagnosis, pain and anxiety in fear of death. Spiritual issues also found as patient asked us, while he was alive, I have not done any wrong with others. Then why I am in so adverse pain? During our bereavement support home visit, his wife also shared the same concern. Next, discussion point. How can we support the wife in her grief? As the wife was the primary caregiver, will bereavement support only focus on her? How to make the wife economically independent or stable? Thank you.
Thank you very much, Kweli. So let's try and answer these three questions. How can we support the wife in her grief? Any thoughts? Please feel free to unmute and speak up or use the chat box. And let's try and have a little bit of an engaged discussion here. How can we support the wife in her grief? Are there ways in which specifically we can any specific interventions that anyone thinks might be useful? She spent a large part of her life, large part of the last few years just looking after him, and apparently moving everything around just to be able to take care of her husband. So much so that they've moved him into her father's house. So now, what would be one of the tasks of grief that we need to help her with? Yes, it is a difficult situation, but if we break it down into small bite-sized chunks, perhaps we can try and... Can you just go back to 2 slides, please? One more.
Yes, ma'am.
Yeah. Can we engage her with something? She's also living in her brother's house, right, Kuheli?
Yes, ma'am.
Yeah. So the second last point is now she's living in the brother's house, and okay, so I can see some answers coming in. And empathize with her and make her acknowledge the fact that her husband is no more. Is acceptance a problem? Suggest joining a support group for spouses of individuals with similar mental health challenges, sharing experiences. Yes, support groups can be very helpful at this point. Discussing ways of financial independence. What are some of the ways in which we can help her become financially, at least not independent, but at least a little bit more self-sufficient? Social support for earned livelihood. Yes. Can you move 1 slide forward, please? If you see if you see the second half of the slide, feels guilty if it could have been noticed much earlier. And how do we handle her guilt? Anup,
I
yes.
think with the information, because the people don't know, in most of the people in India, 90% of it diagnosed at stage 4. So she is not the only who skipped it for a long time. Everyone diagnosed at late stage, because the disease, when they start causing symptoms, it's already spread to the other part. If she's given the right information, then she won't have this guilty. But like doctor, how the communication was given, you should have come us to earlier, we should have saved the life. But the fact is, if the person don't have any problem, why he'll visit the doctor? So information can help her.
I think that's an excellent suggestion, Anup. Thank you very much. And this is exactly the kind of information that is missing for a lot of people, because this idea that had I paid more attention, had I picked it up earlier, and like Anup very, very rightly said, there's a reason why cancers are picked up so late, especially in our country. Yeah. So thank you very much. Can we just go to the last slide, to the discussion slide? Okay. As the wife was the primary caregiver, will bereavement support only focus on the wife? Yes, no. Will bereavement support only focus on her? No, Jayanta says. Who else?
Especially the first daughter's family.
Yes. And it seems like the siblings of the wife have been quite engaged in a lot of ways. So so that kind of bereavement support is also important, because they have now taken on, the care of the caregiver. Should be focused on all family members, correct? Yes, both daughters, those closely associated with the departed. Okay. All right. So while I think so bereavement support can be extended to everybody with specific, I think, more intensive follow-ups with her, because she was on the front lines looking after him and caring for him and things like that. Okay, how to make the wife economically independent or stable? This is a long answer to this, but some people have said, there are support groups, but also looking at if she, if in Kerala, what we do is we also look for cottage industry things, women's co-ops, things like that, where she can go and actually do some vocational rehabilitation for herself. It also gives her time to interact with other people and make a and make an and Kudumbashri, of course, and make and earn a living on the side. Okay, please stop sharing screen. Thank you. Yeah. Okay, we are over time, but I will just take if it's okay with this group, I will just take 5 more minutes. We are at the end of this grief and bereavement module. I will share with you notes on these 2 topics, and I'll send it to you through our Tips Echo team, which really just fleshes out the last 2 sessions that we've had. Like I've said before, there is plenty of information available on grief and bereavement. A lot of the evidence and a lot of the literature is from Western context. So please, when applying it, it needs to be contextualized to our own cultures and sensitivities, sensibilities. So that discretion is yours. But any final thoughts? And if for those of you for whom these sessions have triggered difficult memories, I'm really sorry. I hope that you have support in your networks. And if anything in particular has stayed with you that maybe you need to unpack a little bit more, then please do reach out to us, and we will try and support you in a way that is possible. But if there are any final comments or questions, now is the time to ask them before we disband. Okay. All right. So shall we take our leave then, Rajika and Sangeet?
Yes, ma'am. Thank you so much, ma'am. And thank you all for joining. If there's any other concerns, maybe you could put it in the WhatsApp group, and there are doubts or queries, anything. Okay. Thank you so much. Have a great day.
Thank you.
Thanks very much. Goodbye.
Thank you, ma'am. Thank you for the brief session. Thank you. Thank you, Rajika, for the facilitating. Thank you all for participating. See you in the next class. Thank you. Bye.
Thank you. Bye.